Hi, I'm Sharonda, and I am here to review some vocabulary words that have been seen on the recent CNA exams. And I have grouped these vocabulary words under nursing assistant responsibility. We're going to first begin by talking about admitting a resident. When a resident has been admitted, the resident have been allowed entry into the healthcare facility and they are beginning care. As a nursing assistant, you want to be empathetic and compassionate to the new resident, understanding that they are experiencing change. And in the process of change, you have some residents that are depressed when they're moving into a long-term care facilities. And then you have some, that are happy about being in a situation where they can have that 24-hour care. You want to prepare the resident's room prior to them arriving, and you want to introduce yourself once they arrive. You want to give them your name and your title. You make sure that you're introducing yourself to the resident and the family members. You want to offer a tour of the facility to the resident, and then also you can explain some of the day-to-day activities that occur within the facility. You want to make sure that you have patience and that you don't rush the process of the admission. Once you get the resident to their assigned room, you want to introduce the resident to their roommate and also some of the nearby neighbors that they may be close to. You want to show the resident their room, you want to show them their bathroom, and then also you want to explain to them how to work things within the room. You want to explain to them how to work the telephone, the call light, how to turn the lights on in the room, how to dim the lights, how to turn the TV on, how to operate the bed that they will be sleeping in. You just want to make sure that you are orienting them to the things that are in the room. You also are going to provide them with an admission packet. And so that admission packet usually involves a basin and other personal care items like a toothbrush, a hair comb, toothpaste, mouthwash, body lotion, and things of that nature. You want to handle the resident's personal items with care and respect, and you will also help the resident put those items away. When possible, you're going to allow the resident to decide where items are placed and how the room should be set up. If required, you're going to take vital signs and measurements to establish a baseline for their measurements. A baseline is the measurements or the resident's vital signs, height, and weight upon admission. Future measurements are going to be compared to the baseline or the initial set of measurements that have been taken on that individual. You also want to take inventory and create a personal item belonging list that will list all the personal items that the resident had on admission into the facility. Depending on the facility policy, you're going to label their personal items and their personal care items. You want to make sure that those items are labeled because you don't want to share items from one resident to the other. And the new resident may be sharing a room with someone that they don't know. So once again, you're going to help those residents put their items away, and you want to notify the nurse if the resident has valuables, and that nurse will give you further instructions on how you should store or handle the valuables that the resident came in the facility with. Next, we're going to go through a quick vital sign review. We're going to talk about the 5 vital signs. You have your temperature, your pulse, respiration, and blood pressure. Pain is considered the 5th vital sign. While we're talking about pain, I would like to discuss phantom pain. You could see that on your test, and phantom pain is pain that is present in an amputated limb. The equipment that you need to measure vital signs will include a thermometer. You will need a watch with a second hand when you're counting their pulse. You'll need a stethoscope. You'll need a sphygmomanometer, a blood pressure cuff. You'll need alcohol pads, pens, and paper. It's important when you're gathering vital signs that you know that particular resident's baseline. And once again, the baseline is the measurements of a resident's vital signs, their height and their weight upon admission. All future measurements from their residents will be compared to the initial set of measurements that they had on admissions or their baseline vital signs. You want to know that the advantage of taking an oral temperature is that it is the least uncomfortable method, and it is the most common site used when we are taking a temperature. When measuring body temperature, the most accurate temperature is going to be the rectal temperature. The average temperature for an adult is 98.6 degrees. Thermometers can be color-coded. Blue, the blue end of the thermometer is for the oral or the mouth and axillary temperatures, and then the red tip thermometer is for the rectal. You never want to use the red tip thermometer in the mouth or the blue tip thermometer in the rectum. You should use the appropriate monitor for the orifices that you're measuring. A glass thermometer contains mercury, which is the reason why they're not widely used in the healthcare industry now. Because the glass thermometer contains mercury, it must be shaken down to a temperature of 95 degrees before you use it. When using a glass thermometer to take the person's temperature, you want to assist the person. You want to make sure that the person is not biting down on the glass thermometer, because this monitor does have mercury in it. And if it is broken by the teeth of the person that you're measuring the temperature, that person is at risk for injury from the glass breaking in their mouth or from being exposed to the mercury that's within the glass thermometer. You do not measure temperature orally if the person is receiving oxygen. How far should a glass thermometer or a thermometer be inserted into the anus? It should be inserted at least an inch or in half an inch, at least 1 inch, and the opening must be lubricated. Once again, if you're taking a rectal temperature, you would insert the thermometer into the anus at least 1 inch. When you're taking a rectal temperature, the position that the patient should be lying in is the Sims position or the left side lying position. For a rectal temperature, for an axillary temperature, you should hold the thermometer in place at least 5 minutes or until you hear it beep. In order to take an axillary temperature, you want to make sure that the underarm is dry and it is held close to the body. Measuring the temperature in the axillary is not the preferred method to take a temperature. It should be done as a last resort. When you are taking a tympanic temperature with a tympanic thermometer, you should pull the earlobe toward the front of the ear. After pulling the earlobe up and back by the top portion. You're going to insert the tympanic thermometer inside the ear, toward the front of the ear, and then you're going to pull the ear up and back by the top portion of the ear. A digital thermometer can be used orally, axillary, or rectal. Remember, blue is for oral and axillary, and red is for the rectum. We also have a temporal thermometer that allows you to take the temperature by sweeping the thermometer across the resident's forehead. What is a pulse? What does it include? The pulse is a measurement of the heartbeat, and it includes the note, the noted rate, the rhythm, and the volume. What is a normal pulse? It's 60 to 100 beats. While we're talking about pulse, let's talk about the apical pulse, where the stethoscope you will need to listen to the heart for at least 1 minute. Remember, with the apical pulse, the instrument that you will need to gather the apical pulse is a stethoscope, and you must listen to the heart at least 1 minute. When we have a rapid heart rate or a rapid pulse, this is called tachycardia. A slow heart rate or a slow pulse is called bradycardia. The respirations are the breathing rate, and you want to be noting the rate, the rhythm, and the depth of the person that's breathing. A normal range for respirations is 12 to 20. And you shouldn't let the resident know that you're counting their respirations if possible, because some residents will hold their breath if they know that you're counting their respirations. You should measure respirations for at least 1 minute. If you are measuring respirations that are irregular, you should count for at least 1 minute. One respiration is the equivalent of inhalation and inspiration. So basically, you're going to inhale, which is going to be breathing air into the lungs, and then the resident will exhale, and that's breathing air out. The word eupnea is for a normal respiration rate. Tachypnea is when the person is breathing higher than normal, so over 20 breaths per minute. And bradynypia is when a resident is breathing less than 12 respirations per minute. Dyspnea is difficulty breathing. And apnea is a temporary resuscitation of breathing. What is blood pressure? It is the force of blood against the arteries walls. A normal blood pressure is 120/80. Carotid cuff sounds are the sound of the blood pressure. When you first hear the carotid cuff sound, that will be your top number or your systolic number. And when that sound goes away, that is your bottom number. Your sphygmomanometer is a large word for blood pressure cuff. Systolic is the top number of the blood pressure, which is written in a fraction type form. The systolic is the first sound you hear when measuring the blood pressure, and the diastolic is the bottom number and the last sound that you hear when measuring blood pressure. Hypertension means high blood pressure. Hypotension means low blood pressure. Orthostatic hypertension occurs when people are changing positions. So in order to avoid orthostatic hypertension, you should have your residents sit on the side of the bed and dangle their legs, moving them around in a circle to increase circulation prior to them standing up. This will decrease the chances that they faint once they stand up if you dangle this person on the side of the bed. In the morning, the nursing assistant has a resident sit for a minute before standing and walking to the bathroom. This is going to help them with their orthostatic hypertension. When you are measuring the blood pressure, the resident's arms should be supported on their legs with the palm up above the heart level. The most common artery that is used to measure the blood pressure is the brachial artery. The diaphragm, or the bell of the stethoscope, should be placed over the brachial artery before you measure the blood pressure. For the blood pressure to be accurate, you need to make sure that the cuff is the correct size and that it's fitting appropriately so that you get the right number. The person's arm needs to be level with the heart, with the palm up, once again, prior to you checking the blood pressure. Once a nursing assistant take the blood pressure and you find that the blood pressure is different from the last blood pressure that you recorded, the very first thing you're going to do is check the blood pressure again. And if you're still not satisfied with your measurements, then you would go to the nurse and have the nurse to check the blood pressure. We're talking about weight now. There are 3 different kinds of scales. You have a standing scale, you have a bed scale, and then you have the wheelchair. So when a patient cannot stand independently, but they are able to get out of bed, they use a chair in order to weigh them. The reasons that we weigh a resident is because a resident's weight helps us to evaluate the nutritional status for that patient. A change in their weight can be an indication of an early disease process. Medication dosage is often determined by a patient's weight, is another reason why we record our residents' weight. When preparing to weigh a resident, the very first thing the nursing assistant should ask the resident to do is to urinate or to void if they need so. Remember to always use the same scale when weighing the resident. You want to use the same scale and you want to weigh them at the same time of day to obtain the most accurate measurements. So once again, the amount of heat in the body is called the temperature. You have your 4 sites for temperature reading. That's going to be your oral site, your axillary site, your rectal temperature. I want to remind you that older people have a lower temperature than normal. The rate of the heartbeat is called the pulse. The number of heartbeats or pulse felt in 1 minute is the pulse rate. Your normal pulse rate is anywhere from 60 to 100. You want to report pulse rates that are below 60 and pulse rates that are above 100. The rhythm of the pulse should be regular. And a regular pulse occurs when beats are not evenly spaced or they are skipped. When the pulse is easy to feel and strong, we consider that pulse to be bounding or a strong pulse. A pulse that is hard to feel is considered a weak pulse or a thready pulse. Respiration is breathing. That's a combination of inhaling and exhaling. Your normal respirations are from 12 to 20. We talked about the blood pressure being the force of blood against the artery walls as the heartbeat. We record our blood pressure with the systolic over the diastolic. It looks somewhat like a fraction. Your normal blood pressure is about 120 over 80. You want to report blood pressures that are low. For example, 100 over 60, you will report to the nurse. You want to report blood pressures that are high, beginning with 140 over 90. Systolic is the top number of the blood pressure. It's the amount of force that is needed to pump blood out of the heart and into the body. The diastolic blood pressure is the pressure in the arteries when the heart is at rest. So the systolic, the top number or the systolic phase of the blood pressure is when the heart is contracting, and the diastolic phase of the blood pressure is when the heart is resting. Hypertension is high blood pressure, and hypotension is low blood pressure. We talked about the sphygmomanometer. It's a cuff and measuring device used to measure your blood pressure. The best time to weigh a person is going to be before breakfast. If you got to weigh somebody every day, make sure you use the same scale and weigh them at the same time. We're going to talk about signs of infection. There's going to be temperatures that are elevated, a person that's chilling and sweating, they have hot or cold skin, their color is flushed or bluish or inflamed. All of these are signs of infection, and they should be reported to the nurse. Urine should be straw color or pale urine. You're going to report urine that's dark, red, or cloudy in appearance, or has the presence of solid particles of blood within the urine. Dehydration is low fluid intake. You're going to receive, or you're going to be able to see output of dark urine with strong odor. And with dehydration, the residents can lose weight, have dry skin, and dry mucous membranes. When a person is retaining fluid, they exhibit symptoms on their body. So a person, signs of fluid retention would be edema, swelling, weight gain, and respiratory difficulties. Urinary complaints from a resident would include dysuria, and that is pain during urination. They can complain of burning, urgency, frequency, and they can also refer to flank pain or pain in their back. Remember, dysuria is difficulty breathing. If you are preparing to take an oral temperature and the patient just finished eating or drinking, you want to wait at least 15 minutes before you make an attempt to capture that measurement in order for the measurement to be accurate. Bowel and bladder training are measurements taken to restore function of urination, defecation by a resident with the goal of continence. You want to encourage fiber foods, encourage regular exercise. You want to teach good pericare. You want to keep their bedding clean and odor-free. When the resident awakes, You want to take them to the bathroom when they awake, 1 hour before their meals, and then every 2 hours between their meals, and then also before they go to bed. So you want to encourage them to urinate at scheduled intervals. You want to be aware of the client's current voiding habits. If you notice that the client is urinating every 30 minutes, the goal is to gradually increase the time between the intervals by 5 to 10 minutes. So if you have the resident on a schedule in order to help bladder train them, then their fluid intake should also be on a schedule. Kegel exercises are taught to help prevent leaks. And in order to be compliant with your bladder training, you don't want to give the resident fluids 2 hours before they sleep. You want to remember to give positive reinforcement, be empathetic if the resident is incontinent. You want to make sure that you are following standard precautions. Make sure that you explain the bowel training schedule to the resident, just like you explained the bladder training schedule to the resident. And then you follow that schedule carefully. You want to keep a record of their bowel habit. You want to take notice a pattern to predict when the resident will need a bedpan or a trip to the bathroom. You want to encourage them to drink plenty of fluids. You want to encourage foods and high in fiber. Make sure that you're answering that call light promptly. You want to provide privacy. You do not want to rush. You want to help the resident provide peri-care. You want to discard any waste. And you want to praise your resident for success. And when you're discarding the waste, sometimes, especially if it's a bowel movement, you want to bag it prior to putting it into the garbage can. When you're being empathetic, this is identifying the feelings of others, is caring about other people's problems. In other words, you think about what it would be like to be ill or to be dependent like some of these residents. Let's talk about tube feedings. They are used when residents have swallowing difficulties but are able to digest food. So as a nursing assistant, you do not insert tubes or give the feedings or suction the tubing. Now, what you can do is assemble the equipment for the nurse. You can position the resident. You can observe the tubing site for signs of infection, and you can clean around the site. And you can assist in storing the equipment and supplies. As a nursing assistant for your residents that are receiving tube feeds, you should make sure that the resident is positioned in an upright position during the feeding and for at least 1 hour after feeding to prevent aspirations. You want to report signs of aspirations like coughing or choking to the nurse. When a person is receiving tube feedings, they may have a dry mouth, so you want to give frequent mouth care to prevent dry mouth in the residents that have tube feedings. You want to be observant of your resident that has tube feedings, and you want to notify the nurse if the tubing becomes disconnected, if the actual tube comes out of the abdomen, if the resident exhibits any signs of aspiration, and aspiration is inhaling water or fluid or a foreign object into the lungs. You want to notify the nurse if the person is in respiratory distress. Notify the nurse if the pump alarms, if the tube feeding liquid begins to gather in the resident's mouth, if the tubing is kinked, clogged, broken, or cracked. You want to notify the nurse if the resident is pulling on the tube. You want to notify the nurse if there are signs of infection around the tube site. And those signs of infection would be the skin feels warm and red. You may see sores or swelling. You may even see pulse. All of these things should be reported to the nurse. Also report any signs of dehydration, any nausea or vomiting, any bleeding or any drainage since you've been discharged from the hospital. When we are transferring a resident, we are moving a resident from one place to another. You want to make sure that the strong side moves first, followed by the weak side. You want to stand on the weaker side. When moving a resident within the bed, always get assistance regardless of the resident's weight. Even if the resident weighs 60 pounds and you feel like you can turn this resident on your own, you will always go and get assistance when it's time to transfer or move a resident in regard to the CNA State exam. Dangling allows the resident to sit up with the legs hanging over the side of the bed in order to gain their balance. Dangling helps residents to regain their balance before standing up. It helps them to equalize their blood flow. It returns blood flow to the head and allows the BP to stabilize. Dangling prevents dizziness and lightheadedness that can occur when a person stands up or change positions. Log rolling is moving the person as a unit without disturbing the alignment of the body. The head and neck must be kept in a straight line. This is necessary in the case of a neck or bone problem. In the case where there has been a head or spinal injury, after neck or back surgery. Ambulation. Ambulation is walking or moving with or without an assistant device. As a nursing assistant, you should use a transfer or gait belt with non-slip socks when you are ambulating a resident, especially when you're ambulating them for the first time. You always remember to follow the care plan. It's going to tell you how often the resident should ambulate during your shift. When you are walking with the resident, you want to walk slightly behind them and to one side of the resident for a full distance while holding on to the gait belt. If residents have if the resident has a weak side, you want to stand on the weaker side. Use the hand that is not on the gait belt to offer support on the weaker side. You want to ask that resident to look forward and not look down when you're ambulating them. Remember, if the resident becomes dizzy or faint, help them to clearly or neatly sit where they are and call the nurse for help. After you're done ambulating the resident, it's okay to go ahead on and remove the gait belt. What is a gait belt? It's a safety device that's used to transfer residents who are weak, unsteady, or uncoordinated. If secured around the resident's waist, you want to make sure that you place it over the clothing and not against the bare skin. That transfer belt is going to give you, as a nursing assistant, something firm to hold on to when you're helping the resident to transfer. You don't want to use a gait belt if a resident has fragile bones, fractures, recent abdominal surgery, or chest surgery, if they've had a back injury. You want to make sure that the gait belt, once it is applied, is snug, but it's not too tight. You never want to apply a buckle over the spine or a wound. Make sure of skin folds, or make sure that the skin is dry and that the belt is not directly up against the skin under skin folds. You want to, once you get the belt in place, you tuck the excess strap. So a quick review, your gait belt is going to be the same thing as your transfer belt. When you get ready to ambulate a resident that's walking a resident, you want to make sure that that gait belt is in place, and that or your transfer belt is in place. You want to make sure that the buckle is not up against the spine. You want to make sure that the buckle is not up against a wound. You never want to place the butt buckle on the actual spine of a resident or over a wound. You never want to place the gait belt over a pregnant belly. If you are using a gait belt on someone that's pregnant, you want to put the gait belt up under the armpits and around the upper chest. You always want to slide your hand in between the gait belt, and you want to check with the resident to see if the gait belt is too tight. If it is, you can adjust it at that point. The excess strap of a gait belt needs to be tucked. Vision impaired. Impairment is the loss of partial or complete impairment of function or ability. When a person is nearsighted, this is called myopia. This is the ability to see objects that are near more clearly than objects that are away. And then farsighted is hyperopia. This is the ability to see objects clear when they are far away, more so than they are close to you. A cataract can cause visual impairment. Cataracts occur when the lens of the eye that is normally clear becomes cloudy. Glaucoma can contribute to visual impairment. It is increased pressure in the eye, causing damage to the optic nerve. As a nursing assistant, when you're taking care of visually impaired residents, you want to knock on the door, announce yourself. You do not touch the resident until explaining who you are and what you are planning to do. You're going to face the resident the entire time that you are speaking to them, also while you are providing care. For the visually impaired resident, you want to make sure that there is proper lighting in the room. You also want to use an imaginary clock as a guide to explain the position of objects in the room, so that the resident is aware of where things are. When taking a resident that's visually impaired to a new area, you want to orient them to the objects in that room. If a visually impaired resident wears eyeglasses, you want to make sure that their eyeglasses are clean and they are using them. If they have poor fitting eyeglasses or damaged eyeglasses, you want to report this to the nurse. A person with vision loss is at risk for falls. So you do not move personal items or furniture. Put things back where you found them. You want to let the resident know when you are leaving the room. If the resident has a guide dog, you don't want to play with it, distract it, or feed it. You want to be empathetic as a nursing assistant. You want to try to imagine what it feels like to not be able to see well. When you're working with a visual impaired resident, you want to use large print books and large clocks when they are available. When we're working with our hearing impaired residents, you need to know that there are several types of hearing loss. You know, you have your gradual hearing loss. Some people are born with hearing impairment. Some people have partial loss of hearing in one ear, and then some people have complete loss of hearing. Remember, some hearing loss can be temporary due to wax buildup or sinus congestion. As a nursing assistant, you want to report to the nurse if your resident has trouble hearing high-pitched noises, if they have trouble hearing in a setting with background noise, if they don't understand the meaning of certain words, if they have trouble hearing people when they are not in the same room with them, if they're favoring one ear over the other, if the resident is complaining of hearing ringing in their ear or pain in their ear. As a nursing assistant, these are the observations that you will report to the nurse. For the hearing impaired resident, you want to look directly at the resident when speaking with them because they may read lips. If the resident wears a hearing aid, make sure that they're wearing it and that the hearing aid is turned on. You want to speak clearly, and you do not want to shout to the hearing impaired resident. It's okay to lean over and speak into their ear. If the person favors one ear over the other, then you will speak on that side. When communicating with the hearing impaired, you want to lower the pitch of your voice. You don't want to chew gum, eat, or cover your mouth when you're speaking to the hearing impaired resident. Use simple words and short sentences. You can use pen and paper or picture cards when needed when you are working with a hearing impaired resident. When you're communicating with them, it's okay to turn off the TV and the radio if needed. When taking care of the depressed resident, major depression is a type of mental health disorder that causes withdrawal, lack of interest in activities, loss of appetite, loss of energy. It can be managed, it can be cured, it can be caused by a recent move into the facility, loss of a spouse or friend, loss of ability to care for themselves, loss of health, loss of independence, loss of mobility, which is the ability to walk or move around, a lack of visitors and family friends, sharing a room with a stranger. All of these things can cause the resident to be depressed. Nursing assistants should be supportive and compassionate, and you should try to make every day a pleasant experience for the resident. For that depressed resident, you want to make sure, for our residents, you want to make sure that you are pleasant, respectful, and supportive. You want to use touch if it helps comfort the resident. You want to sit down and listen carefully by leaning forward and maintaining eye contact when you're communicating with the resident. Always think before you speak and remember to be empathetic to your depressed resident. You want to use a normal tone of voice, use simple, clear statements. You do not talk to adults as if they are children. Another thing, you want to encourage social interaction with other residents in the facility for that depressed resident. You want to talk about their feelings if they choose to do so. And remember, you want to report any signs of depression to the nurse. Your angry or combative resident, anger is a normal human emotion, and it is a normal experience for the resident, for staff, and families. Residents may feel angry due to illness, fear, pain, grief, loneliness, or loss of independence. Anger can be part of a resident's personality. When anger increases, a person may become combative or violent or hostile. At that point, a care conference may be planned to develop a care plan to reduce this type of behavior from the resident in the long-term care facility. A nursing assistant's input in the patient's conference is very valuable because that nursing assistant spends quite a bit of time with the resident. So the nursing assistant can help identify the cause and give some suggestions to reduce the anger. Combative behavior may be a result of a disease process that's affecting the brain, like dementia. You want to be aware of signs and symptoms of anger, which is going to be a resident with clenched or raised fists, a resident that's yelling, throwing things, a resident that's being sarcastic, a resident that's pacing, a resident that's threatening other residents, or a resident that is silent or withdrawing. All of these can be signs of anger that you should report to the nurse. Signs that the resident is combative are similar to those of when they are angry. They're yelling, they're hitting, they're kicking, they're throwing things, they're biting, they're spitting, they're insulting others. They may even be resisting care, pacing, their body might be tense, their face can look flushed and angry when a resident is angry or combative. What should you do? You should notify the nurse. You should stay calm. You don't want to appear to be threatening. You want to speak in a normal tone. You want to stay neutral. You do not want to respond to an insult. And you most definitely do not argue with an angry resident. You don't argue with any resident, but especially one that is angry. You want to be pleasant and support the resident. Let the resident know that you are there to help them. Try to find out what is the cause of their anger, what might have triggered the behavior. Using silence may help the resident explain. You want to make sure that you're always observing their body language. Once again, you're going to empathize with the resident. Imagine how you would feel if you were in this position. You want to treat your resident with dignity and respect. For your anger and combative resident, you want to answer all call lights promptly for all residents. If the anger continues to increase, it's okay to go and get the nurse. You want to stay at a safe distance if the resident becomes violent. Never hit or physically assault a resident. Your confused resident. This is the inability to think clearly and logically. It interferes with the ability to make decisions and make changes to the resident's personality. It can be temporary or it can be permanent. Once again, that confused resident has the inability to think clearly and logically. The confusion interferes with the ability for the resident to make sound decisions, and it may change the resident's personality. Once again, confusion can be temporary or it can be permanent. And some of the causes of confusion can be low blood pressure, the person is having a stroke or recently had a head trauma, they dehydrated, they may have a severe infection, they can have a brain tumor, seizures, and lack of oxygen. Some things that can cause the resident to be confused is medication, illness, and then loss of sleep. What should you do as a nursing assistant? You do not want to leave the resident alone. You want to stay calm. You want to provide a quiet environment for the resident. You want to speak clearly and slowly in a lower tone. You want to introduce yourself each time you see them. You want to remind the resident of their location. Always remember to be patient. Explain what you're going to do before you do it. Make sure you're using short and simple terms that's easy for the resident to understand. You want to keep a routine. This will help the resident understand or know what's going to happen before it actually happens. You want to encourage the use of their eyeglasses or hearing aid if they have one. You want to tell the resident when you're leaving the room. And any observation that you notice, you want to notify the nurse from that confused resident. The confusion may be new. It could be of new onset. So you always want to be in communication with your nurse. Your wandering residents, they're walking aimlessly around the facility or the facility ground. And a person that wanders can wander on foot. They can wander on a bike or in a car. A person that's wandering has poor judgment. They sometimes are unaware of danger and they can't really tell what's safe. This can be life-threatening because they can wander out into ongoing traffic. They can have an accident. They can walk out into the ocean or into the forest. If they're not properly dressed when they're wandering, they can experience exposure to cold or overexposure to heat. And a wandering resident is at high risk for falls. So as a nursing assistant, understand that wandering is allowed in safe areas and in locked units. But you don't ever want to leave a resident alone. You want to keep doors and windows locked. And some things that you can do to help reorient that wandering resident is to place stop signs on doors or do not enter signs on doors. You want to use door chimes that would alarm when the door is open. That way you know if the wandering resident is trying to elope, because that door chime will alarm. And elope, that means to wander outside of the facility. If you see a person that's wandering in an unsafe area, you gently want to, take them back to a safe area. And it's also a good idea to notify your staff members and other staff members when you have a resident that wanders. That way you have several eyes looking out for this resident. Suicide is the act of taking one's life intentionally or purposefully. You don't ever want to promise a resident that you will not tell their plans to kill themselves. Doing so puts this resident at risk for injury. You want to observe for warning signs for a potential suicide, like the resident talking about killing themselves, them describing a method that they're going to kill themselves, or them establishing a timeline, or a resident giving away their belongings. If you observe any of these warning signs, you want to make sure that you notify the nurse. You want to make sure that you remove potential hazardous items out of the resident's environment to protect the resident from harming themselves, like razors and other sharp items or cords. You want to take those things out of the room if a person has expressed that they want to kill themselves. So if a resident discloses to you that they plan to kill themselves, you want to stay with the resident and you want to call for help so that you can notify the nurse. A suicidal resident requires frequent monitoring, and it's also a good idea to use plastic dinnerware when they are eating. Sexuality in our residents is physical, emotional, social, and cultural and spiritual factors that affect a person's feelings, attitude, and their behavior about their gender identity and their sexual behavior. It's absolutely normal. It involves the personality and the body. Sexuality is how a person behaves, how they think, how they dress, and respond to others. It begins when they are born. When a baby's biological sex is known, sexuality begins. It's important throughout the entire life. It does not decrease with age. It's a common myth that older people do not like to have sex or don't have a sexual appetite, and that is incorrect. Sexuality does not decrease with age, but it is affected by life events. So as a nursing assistant, you should make sure that the resident that you respect, that the resident respects professional boundaries, that they're not getting out of line with you as their caretaker. You do not allow inappropriate touch or language from a resident. You're going to report this to a nurse. You definitely don't want to allow the resident to refer to you as a girlfriend or a boyfriend. This is highly inappropriate and crossing professional boundaries. You want to redirect that resident and notify the nurse. Some things you can do to help the resident is to let the person practice grooming, their own grooming routine. Let the person choose their clothing. You want to protect their privacy. You don't want to expose the person unless necessary. And you want to treat your residents with dignity and respect. You should not be sharing your sexual attitudes, values, or practices with the resident. These residents may have premarital or extramarital relationships. that you witness just because you're working in their home. You do not want to judge or gossip about the person. If a person, a married couple, or two residents are having sex, you want to allow for privacy. If they are masturbating in the dining room, you want to return them back to their room and provide them with privacy. You always want to knock before entering a resident's room. Usually, married couples can share the same room, and if their health permits, they can share the same beds. Also, be aware that relationships may develop between different residents while they are in the long-term care facility, and they are allowed to spend time together. Do not, make an attempt to try and keep them apart. Residents' independence. You want to promote and encourage independence. This is vital to rehabilitation. You want to allow the resident to do as much as possible for themselves. Independence helps with their self-esteem, along with helping them to recover quickly. It allows the body to stay active, and it prevents complication of immobility or patients that aren't moving. You want to use verbal and physical cues to promote independence. And you're using verbal and physical cues when you are helping the resident complete activities of daily living. A verbal cue is a short sentence of words that direct the person to complete a specific step. For example, the nursing assistant can say, "Take a sip of water." A physical cue is when the nursing assistant is showing the person how to do the activity. For example, the nursing assistant places her hand on the resident's hand around the cup while helping them to bring the cup to their mouth for a drink. As a nursing assistant, residents should be allowed to make as many choices as possible to maintain their independence. Our residents have the right to choose their food, their clothing, their doctors, their visitors, and how much time they spend in each one of those situations. It is their legal right for them to choose the food, the clothing, the doctors, the visitors, and the time that they spend. And allowing them to do these things encourages their independence and promotes personal centered care. That's what we're all aiming for, person-centered care for each individual that we're providing care for. A pressure ulcer, it is also called a pressure injury or a decubitus ulcer or a bed sore. The sores or wounds that result from skin deterioration or shearing. It's easier to prevent a pressure ulcer than to care for one. If a pressure ulcer is not caused early, it can increase and get deeper and become infected, making it painful and difficult to heal. Pressure ulcers or bed sores can cause life-threatening infections. So prevention is going to be the most important key to skin health. There are 4 stages to a pressure ulcer, and then you have some wounds that are considered to be deep injury wounds. You have some wounds that are unstageable. As a nursing assistant, you should observe the skin for injury, inspect the resident's skin every time you provide care, and you want to follow the care plan and the person's position schedule when you're positioning the patient. You should be positioning bedfast residents at least every 2 hours, and then you're going to reposition chairfast residents at least every hour. You're going to use pillows for support, and the head of the bed should be at least 30 degrees. Do not reposition the person on a pressure injury itself or a reddened area or on tubes or other medical devices. You do not want to leave a person on the bedpan for longer than needed. You do not let the person sit on a donut-shaped cushion. You want to prevent shearing and friction during moving and transferring procedures. You do not want to drag the person. You want to completely lift the resident up off the bed during moving or transferring. You also can use an assistive device to help prevent shearing or tearing of the skin. You use pillows, foam wedges, or other devices to prevent bony areas from contact with bony areas. The ankle, the knees, the hip, and sacrum are examples of bony areas. Remember to keep heels and ankles off the bed. You want to float them. Your pillows, you want to place them under the mid-calf. And you want to elevate the legs when the person is sitting in a recliner. The care that we provide should help us to prevent skin breakdown, which ultimately leads to pressure ulcers. Skin breakdown is changes or damage to intact or normal skin and skin layers. You need to know that the top layer of skin is called the epidermis. When a person is confined to the bed for a long time, the amount of blood that circulates to the skin, it gets reduced, which puts this person at risk for breakdown. Moist and warmthness of the skin also contributes to skin breakdown. Remember, shearing is rubbing or friction resulting from the skin moving in one way and the bone underneath the skin remaining stable or fixed or moving in the opposite direction. Skin breakdown usually occurs at the area of the body that bear the most weight. These are called pressure points. Many pressure points are on the human body. They can also be called bony prominences. Bony prominences are areas of the body where bone is closer to the skin. And you want to protect the skin by placing pillows in between those bony prominences. Skin breakdown could be common on the elbow, the shoulder blade, the sacrum, a resident's hips and knees. They can break down on their ankles, on their heels, their toes. They can even break down behind their ears and under their breasts. So you really need to be observing their skin in order for you to report any of this breakdown. They can have some breakdown on the back of their neck, on their head. They can have it on their scrotum, between their buttocks, or on their abdomen. They can also have it between their legs. So remember, pressure and shearing causes skin breakdown that can lead to pressure ulcers. Always remember to reposition your residents with the help of a coworker, and you want to position them according to their care plan. A colostomy bag. You want to ask the nurse to determine if the colostomy is actually a colostomy or an ileostomy. A colostomy is a surgically created opening into the large intestines to allow stool to be expelled. Stool in a colostomy will appear semi-solid. Then you have your ileostomy. It is a surgical opening created into the end of the small intestines. In an ileostomy, stool will appear liquid, and it could irritate the skin. Residents that have a colostomy or ileostomy have a ostomy, and they wear a disposable pouch that sits over the ostomy to collect the feces. The pouching system is attached to the skin by adhesive, and a belt might be used to secure it. You never want to cut or puncture a pouch to release the flatulence or the gas that accumulates in the pouch. You want to remember to follow standard precautions when you are emptying the colostomy or ileostomy bag. You want to wash your hands, and you want to wear gloves before the procedure, and you're going to wash your hands after. Remember to provide privacy when you're emptying a colostomy bag. If they are bedridden, you can also use a bath blanket. You want to place the bed protector under the resident and use a towel to protect their clothing. You want to place tissue in the toilet to help prevent splashing when you are emptying the stool. When you are emptying the colostomy bag, you want to expose only the ostomy site. You want to remove the ostomy bag. Place it in the plastic bag for disposable once you have removed the ostomy bag, as opposed to emptying the ostomy bag. You want to notify the color. You want to notice the color, the odor, and the consistency in the amount of stool that's in the bag, whether you empty the bag or whether you change the whole bag within itself. You wipe the area around the stoma with those disposable wipes, and you discard those wipes in plastic bags. Use a warm washcloth when you are cleaning around the stoma, and you want to clean in one direction away from the stoma. And then you will pat the skin dry with another towel. You want to place clean ostomy drainage pouches on the resident once you have removed the old one. You want to hold it in place and seal secure to make sure the clamp is on the pouch. Once again, you want to place a clean ostomy drainage pouch on the resident. You want to hold in place and seal securely, making sure that the clamp is on the pouch. You want to call the nurse if the stoma looks extremely red or blue. If any swelling or bleeding is present, you want to report these signs of skin breakdown to the nurse. A colostomy bag should be empty when it's above 1/3 to 1/2 full with stool or flatulence. Flatulence means gas. You can empty a colostomy bag anywhere from 2 to 6 times a day. When you empty a bag, you want to clean the inside of the outlet with the toilet paper or pre-moisturizing wipes. You want to make sure to discard the wipe in a plastic bag. You want to take the tissue and clean the outside of the outlet. And then you also want to clean the inside of the outlet. And then you want to discard it and replace the clamp. So basically, you're going to use a wipe or some tissue to clean the inside of the outlet of the bag, where at the very tip, when you're getting ready to empty the bag, you want to clean that opening with tissue. And then you also want to clean the actual clamp that keeps the bag closed with soap and water. When you finish providing care for the colostomy bag, you want to wash your hands and wash the resident's hands. Atrophy is the decrease in size or the wasting away of tissue. With atrophy, tissue shrinks in size. With muscle atrophy, this is the weakening and wasting away of the muscles, and as a result, contracture can occur. This is when the muscles are shortened, and sometimes the resident's arms or legs can be in fixed positions that you can't get them out of. Atrophy is a complication of bed rest, lack of exercise and activity. The nursing assistant should promote exercise and activity as ordered to prevent atrophy and loss of strength. Restraints. There are physical restraints and chemical restraints, which restrict voluntary movement or behavior. Physical restraints is a method of device, material, or equipment that restricts a resident's freedom of movement, And there are different types of physical restraints. You have your vest restraints, your belt restraints, your wrist and ankle restraints, your mittens. And then you have your chemical restraints, which are medications that are used to control a person's mood or behavior. Long-term facilities are prohibited from using restraints unless they are medically necessary. Restraints are used as a last result. It is against the law for staff to apply restraints for convenience or to discipline a resident. Doctors must order restraints. Nursing assistants and nurses apply restraints, but the doctor must order them. When restraints are in use, patients are at risk for pressure ulcers. They're at risk for suffocation, entrapment in some part of the bed. They're at risk for severe injury, incontinence, reduced circulation, loss of dignity, depression. They're at risk for poor appetite. They're at risk for death. Make sure your the restraints on the residents are not too tight. You should be able to slip your fingers in between the restraints in order to assure that the restraint is not too tight. And you want to make sure that the call light is within reach. You want to document according to the facility policy. Generally, a resident must be monitored every 15 minutes, and the restraint should be released every 2 hours to provide care. You want to notify the nurse if any problems occur, especially any type of injury to the restraints. Now, if you notice that their fingertips are cyanotic is the medical terminology for the word, or a bluish hue of the skin, you want to release the restraints immediately, and you want to notify the nurse. Also, if you notice that a pulse is not present in an extremity that has a restraint attached to it, you want to make sure that you release that restraint immediately. You want to notify the nurse. So any type of injury or complication, you want to make sure you notify the nurse. Know that the person can die as a result of being restrained and not properly monitored. So you want to look out for suffocation, entrapment. Make sure you're monitoring them every 15 minutes and releasing those restraints every 2 hours in order to take care of, their needs. Whether it's their toileting needs, whether they need hydration, feeding, you want to make sure that you're providing care for them when you release those restraints. Residents that have a cast. Use a pillow to elevate the extremity that is in the cast. This helps to stop the swelling. You do not want to cover the cast with blankets, plastic, or other material. Remember, a cast gives off heat as it dries. If you are using a fan, you want to move the air over the cast. Do not touch the cast in order to maintain the shape of the cast. And if you do have to touch the cast, use the palm of your hands. Do not place a wet cast on a surface because it can flatten the cast. Support the wet cast with your palm to turn or position the person. Fingertips can dent the cast, causing pressure points or pressure areas and skin breakdown. You want to report any rough edges of the cast to the nurse. You want to keep the cast dry. A wet cast loses its shape. You want to use pillows to support the entire length of the cast, and remember to turn the resident every 2 hours. If the resident is in bed, you want to elevate the arm or leg slightly above the level of the heart. You want to observe the affected extremity for swelling, for any skin discoloration, any cyanosis or bluish hinge to the fingers or toes or extremities below the cast. You want to observe for cast tightness or pressure or sores. You want to observe for skin that feels hot or cold, burning, numbness, or tingling. You want to observe for drainage, bleeding, odor. You want to check pulse below the cast. If you don't feel a pulse or the pulse has become faint, you want to notify the nurse. You always want to keep the cast dry and clean. You don't want to insert or allow the resident to insert anything inside the cast when the skin begins to itch. This can cause skin injury or skin breakdown. You can use a bed cradle as needed to reduce pressure from the linings on the cast. And the bed cradle sits in the bed at the foot of the bed, and it allows the linen to flow over it so that the linen is not lying on the person's leg, itself. You want to tell the nurse prior to moving the resident or before the resident exercises if pain medication is needed when a person. So we're talking about the cast. Remember, when you are working with the cast, you want to use pillows to elevate the extremity that is in the cast. This is going to help to stop the swelling. You do not want to cover the cast with blankets, plastic, or other material. A cast gives out heat as it dries, so if you're trying to help to dry a cast, you'll use a fan to move air over the cast. You want to maintain the shape of the cast. You do not place a wet cast on a surface. It can flatten the cast. Support the wet cast with the palm of your hand to turn and position the person, because your fingertips can dent the cast, causing pressure areas and skin breakdown. You want to report any rough edges that can potentially cause skin breakdown to the resident. You want to keep the cast dry because a wet cast can lose its shape. You use pillows to support the entire length of the cast, and you should continue turning a resident every 2 hours. Just because a resident has a cast in place that doesn't mean that you don't have to position them. If the resident is in bed, you want to elevate the arm or the leg slightly above the level of the heart. You want to observe the affected extremity, the extremity that has the cast on it, for swelling, any skin discoloration, cyanosis, which is a bluish hue to the skin, any cast tightness, pressure, any sores, any skin that feels hot or that feels cold. If the resident is reporting pain and burning, numbness or tingling, any drainage or bleeding, any odor that you may smell, you want to report these observations to the nurse. It's okay for you to check the pulse below the cast in the extremity or the arm or the leg below the cast. If there is no pulse or if there is a faint pulse, you want to report this to the nurse. You always remember to keep this cast as dry and clean as possible. You do not insert anything inside the cast. You don't allow the resident to insert anything inside the cast, even when the skin begins to itch beneath the cast. You can use a bed cradle as needed to reduce pressure from linen that may be on the cast. So if the person has a cast on their foot or on their leg, you can place the cradle at the foot of the bed, and it simply allows the linen to flow over the legs or the foot. It prevents the linen from actually touching the leg or the foot. That's the bed cradle, and you can use that as needed to prevent pressure or reduce pressure on the leg or foot that has the cast in place. You want to tell the nurse prior to moving the resident or before the resident begins to exercise, just in case pain medicine is needed. Spiritual needs. Spiritual needs concerns a person's belief about the spirit, the sacred or the soul. Culture and spiritual beliefs may play an important role in the activities before and after death. Spiritual needs are different for each person. Respect the religion and beliefs. Listen when residents want to discuss their religion to provide patient-centered care. As a nursing assistant, you want to honor any dietary restrictions. You want to report requests to see the clergy to the nurse promptly. And once the clergy arrive, the pastor or the rabbi arrives, you want to give that resident privacy. You want to respect all of their religious items. You want to handle their religious items carefully. You want to give the resident time for privacy and for prayer. You want to make sure that the resident who wants to attend a religion service within the facility is ready and present at that service on time. You do not want to try and change someone's religion. You don't want to interfere with their religious practice. You do not discuss your personal beliefs directly or indirectly with the resident. The grieving process you need to know for the state exam. Elizabeth Kubler-Ross developed a theory that dying people experience a common grief process. Her model includes 5 different emotional stages a person experiences before death. Not all people go through all stages. Some stay in one stage and go back and forth between the 5 stages. There are 5 stages. There is the denial. That's the first stage. People may refuse to believe that they are dying. They may think a mistake has been made. They may demand that labs be repeated. This is the not me stage, the denial stage. Anger. This person faces the possibility of death. They become angry. They angry because they think that they are too young to die, or because they have taken good care of themselves, or they've been a good person. So they may direct their anger to the staff, their family member, visitors, roommates, and friends. Anger is a normal reaction. Nursing assistants should not take it personal. This is the why me stage. Bargaining. Once people believe that they are really going to die, they may start trying to bargain with God or their higher power in hope of recovering. They may promise things like, if I'm healed, I promise I will go to church every Sunday, and I will pay my tithes, like I'm supposed to. They begin to bargain for their life. This is the yes, me, but stage. Depression is another stage. They become deeply sad or depressed. They may cry and become withdrawn. They may be unable to do simple tasks. They need additional physical and emotional support. And it's important for the nursing assistant to listen and to try and understand and empathize with this depressed resident. Acceptance, the acceptance stage, the person has peace or acceptance may or may not come before death. When they are experiencing acceptance, they may make arrangements with attorneys, accountants, and loved ones for the care of important people, pets, and belongings. They may prepare for ceremonies before and after death. And during this phase, they may seem a bit detached. Dying is the end of life, the cessation of all body parts. When a person is dying, they still have legal rights to have visitors, privacy. They have a right to be free from pain. They have a right to honest and accurate information, and they have a right to refuse treatment. When a person is dying, it doesn't mean that they require less care. In some situations, they may require more care, more frequent monitoring, more mouth care. You're still going to provide care for the patient. Even when they are dying, you're going to make sure that you give them respect and dignity to the actual resident and the family as well during the dying process. You want to respect any religious or cultural practices that the resident may have in place while they are expiring. What should you do? Make sure that the room environment, make sure the room is ventilated. You want to keep personal items like pictures, religious items, and cards visible or within reach. You want to keep the skin, nose, and mouth. You want to make sure that they have skin, nose, and mouth care. You want to give frequent skin care, bathe the resident as needed. You want to change their gowns and their sheets for comfort. You want to give incontinent care promptly. You want to keep them clean and dry. You're going to give them mouth care frequently and ice chips if they are allowed. You want to use lubricants on their mouth and nose to prevent cracking. Some residents, when they are dying, experience breathing problems. They may have difficulty breathing. Chain Stokes respirations are common. This is the alternating between slow, irregular respirations followed by rapid, shallow respirations. They may have a gurgling or a rattling sound as they breathe as death near. The nursing assistant should notify the nurse if you hear this gurgling, this rattling sound. If the resident is experiencing chain stroke respirations, the nurse may be able to give some medications to increase comfort, to ease the problem with breathing, to assist this resident as they make their transition. You can also elevate the head of the bed and help the resident to change positions to improve their breathing. Food and fluid. These residents have a right to refuse fluid in food. You want to report any signs of aspiration, nausea, vomiting, and diarrhea to the nurse. Pain control and comfort is important during a resident's transition as they are dying. You want to observe body language for signs. You want to report signs and symptoms of pain to the nurse. Diminished their senses begin to diminish as they expire or begin to die. And so remember that hearing is the last sense to leave the body. So when you are communicating with the resident, you want to make sure that you maintain respect and dignity with the resident, while they're alive and even after they have passed. You want to give them the utmost respect. And understanding that even if the resident cannot talk or move, that they can still hear you. So you will be explaining the care that you will be performing to them, when they're at the point where they can only hear you. The care plan is a plan for each resident that's created by the registered nurse. It outlines the tasks that the team members must perform to help the resident meet their goals. Information is gathered from the resident, family, and care team members to develop the care plan. The care plan is going to give you detailed instructions on how the residents how the resident's care should be managed, and it must be followed very closely and carefully. It's going to help provide patient-centered care, and nursing assistants should report signs and symptoms that they observe to the nurse. Objective information is information observed based on what the nursing assistant sees, hears, smells, or touched. It is also called signs. So you're going to report the objective and subjective information, but the difference between the two, your objective information is information that the nursing assistant can see, hear, smell, touch. And then say, for example, an example of objective information, Miss Smith is grimacing, rubbing her temple, and holding her head. So we can see that she is frowning. We can see that she is rubbing her temple, and she is holding her head. Subjective information is information that is reported from the resident or their family, and it cannot be measured. So, for example, Miss Smith is complaining of a headache. Subjective information is whatever the resident says it is. There's no way that we can truly validate whether Miss Smith is experiencing a headache or not. Objective information can be measured. Subjective information is whatever the resident says it is. Documentation is the act of noting care and observation in writing. Nursing assistants document or chart all the care that they provide. All information is confidential. You want to document immediately after the care is given and before the end of your shift. You're going to use black ink when you are documenting by hand. You want to sign each note, including your title. You want to use only facts and not opinions when you're documenting. If you make a mistake, you draw one line through the error and place your initials and date near the line. You do not ever use whiteout correction fluid or try to erase an error. You simply draw a line through that error, date, and initially. Use only the facility approved abbreviations. Use comparison to explain the size of things. Like, for example, an abrasion is the size of the dime, or this wound on the knee is the size of a nickel. Do not share your passwords if computer charting is available or in use. And once you have completed documenting on the computer, you want to log out at once. Know that the resident chart is the clinical or medical chart is a legal document, and it is admissible in court for the resident. So whenever you are documenting, your documentation goes into the medical record, which is a legal document that's admissible in court of the resident's care. Feeding, you want to wash your hands. You want to sit whenever possible. You want to verify that the resident has the right diet and make sure that you're using a barrier. Always raise the head of the bed to prevent choking. You're going to wash the resident's hands prior to them eating. You want to make sure that dentures are fitting properly. If they don't, you want to notify the nurse, because improper dentures are going to affect the way that a resident eats. If a resident is weak on one side, you want to sit on the strong side and place food on the strong side of the mouth, especially if the resident has had a stroke. Use verbal and physical cues to help maintain independence for residents with Parkinson, dementia, confusion, or trauma. You do not sit on the bed. You want to explain what the resident has to eat and drink on their plate. You use a clock for visually impaired residents so that they know where their food is placed on their plate. For example, your chicken is placed at noon so that the resident can maintain some type of independence. Even though they're visually impaired, they may be able to still feed themselves if you're using verbal cues to help them know where the items are placed on their plate by using an imaginary clock. Check the temperature of the food, offer small bites, and allow time for chewing. You want to alternate between liquids and food. You want to report any signs of choking or aspirations to the nurse. You're going to wipe the resident's hands and mouth during the meal. If the residents want different food than what's being served, you want to notify the dietitian or notify the nurse. If a resident refuses to eat, respect their right, but also notify the nurse, especially if they are a diabetic resident. The nurse needs to know if they have not eaten their meal. Supplementing feeding. Residents that do not eat enough may be placed on a special supplementary diet. It is added to the resident's diet. It may come in a powder or liquid form. Some supplemental feedings are already pre-mixed and ready to use. Some supplements are added to milkshakes or Ensure. You want to allow time for the resident to consume their supplemental feeding. And if the feeding is in a powder form, you want to add the appropriate amount of water to the form. Diets are ordered by the physician. Special diets are ordered by the physicians, and they are planned by the dietitian. The physicians order the diet, and the dietitian plans the diets. Nursing assistants should follow each resident's diet plan, and the observation should be made and reported to the nurse. The care plan should specify any special diets that are prescribed for a resident. That's why it's very important that we follow the care plan. NPO is a special diet ordered by the physician. It means nothing by mouth. This person could have a serious problem with swallowing, and it is unsafe to give them anything by mouth. So this diet is put in place. This person could be going to surgery, or they may need to fast before having a certain test. These are other reasons why a diet that states that the person can have nothing by mouth could be ordered. So when a person has this diet, usually there's a sign placed somewhere in the room to help people know that they're not supposed to have anything by mouth. And as a CNA, You want to remove any pitchers or cups or food from the bedside. That will help them maintain compliance with the order that states that they can't have anything by mouth. Your dietitian is a licensed professional who plans clients' diets according to the physician's order to assure the client receives the required nutrients to maintain or restore their health. They access and plan nutritional needs to promote health and manage diseases. And they also teach about diet and healthy eating. Choking can occur when eating or drinking or when a resident is swallowing their medications. People who are ill, weak, or unconscious may choke on their own saliva. A swollen tongue may obstruct the airway and cause choking. To guard against choking, residents should eat in an upright position. Residents with swallowing problems may have special diets with liquids thickened to a consistency of honey or syrup to make it easier for them to swallow. You know, if you notice that a person is choking, you want to first ask, are you choking? And if they answer yes, then you're going to use your abdominal thrust or the Heimlich maneuver to relieve the choking residents. You're basically placing your arm around their waist, balling your fist up and placing one hand over the fist and using quick upward thrust to the lower abdomen to help the person expel the object that they may be choking on. If the person becomes unresponsive, you want to call for help and begin CPR. Dysphagia is when a person has difficulty swallowing due to illness like stroke, certain medications, problems with the mouth or throat, weakness, or food choices. They can also have problems with their teeth or dentures that could cause dysphagia.
Yeah. As a nursing assistant, you want to report signs of the resident eating slow, spitting out food. You want to report problems swallowing small bites of food or pills. You want to report swallowing several times when eating one single bite, frequent throat clearing, food or fluid coming up out of the mouth, coughing during or after a meal, when a resident is choking during meals or while drinking, any gurgling sound in the voice during or after the meal you want to report. While the resident is eating, you want to prevent aspiration. With a resident that has difficulty swallowing or problems with swallowing, you want to prevent aspiration as well. And aspiration is in the inhalation of food, liquids, or a foreign subject into the lungs. You want to place the resident in an upright position that will make it easier for them to swallow. You want to avoid distractions. You want to make sure that you're giving the resident their undivided attention when they're eating. You want to place food on the stronger side of the mouth